Coming up on the Cutting Edge podcast, we're going to be talking about transformation in primary care. Stay tuned.
Check it out.
For me, I'm very much, here's a problem. Let's take care of it. I have a solution for that.
Our goal when we opened was to provide the highest quality care that was possible at a price people could afford.
I literally talk to physicians daily. Kelly, I can't even log in to see my own billing. I have no idea what's going on. I get a report once a month and nobody can explain it to me. I make it a point to train the physicians how to go and pull their own report.
I'm going to be on the course reporting tomorrow afternoon.
You are?
I am. I'm going to follow Jordan Spieth and Will Zalatoris and Scotty Scheffler. I'm not really reporting, but I am going to go watch the park.
Probably drink a couple beers.
Yeah, I might have a beer or two tomorrow afternoon. I mean, that would make my commentary even better.
Hey everybody, welcome to this week's episode of the Cutting Edge podcast. Hard to believe this is season 2, episode 6. I think that puts us right at about 30 episodes or in that neighborhood for a young podcast. We're making progress and continue to have great guests. So I am currently joined by my co-host on the far right, Miss Kelly Payette. Kelly, thanks for joining us. Kind of a last minute fill-in, but always great to have you here.
Thank you.
Then immediately to my right is Dr. Christopher Crow. Dr. Crow, thanks for joining us today.
You bet. Glad to be here.
So this week, we're talking about a practical blueprint for primary care transformation. Primary care is not an area that I'm terribly knowledgeable of, so excuse me if I misspeak or use wrong terms. I'm more on the surgical side of the universe in healthcare, but we felt like this was a really important conversation to have, something we can share with our community online and through social media. Primary care is a big space and it's a huge driver in healthcare, and can't thank you enough for being here. But before we get started, wanted to just make a few mentions. First wanted to thank TexAssist Surgical Assist Staffing, Carrington Advisors, the Catalyst Health Group as a current sponsor. Thanks for supporting the show. Can't thank those folks enough for being part of it. And then, need to make sure we give a shout out to Jen Eaton at Moonshot Marketing Group. Helped create our logo, helped create our brand, helped set all of our social media channels up, and just kind of keeps us out there. So, without further ado, let's move into the conversation, because I think this 40 to 45 minute convo is going to go pretty quick. So, Dr. Crow, you're the CEO of Catalyst Health Group. Let's just go back to the beginning. Tell us about your background personally, and how you've kind of come to where you are today.
It's always a fun question. How far do you want to go back and how long it take? We got 40 minutes.
Yeah.
So let's start kind of where I am and then how I got there. I guess I'm a family physician by training. And yes, I'm the CEO of this group called Catalyst Health Group that has a couple of sub-brands, Catalyst Health Network, which is a network of physicians, primary care physicians, and Catalyst Health RX, which is a pharmacy services in value-based care, serving Catalyst Health Network and others. So how did I get here? I think it does matter. We're all built in ways that ultimately you can look back and see how it happened and make more sense of it. Maybe at the time it doesn't, but I grew up in a little small town called Hillsboro, Texas.
Oh yeah, just south of here.
Just south of here, about an hour. 7,000 people, 3 doctors, and growing up in the 70s, they really took care of the entire town. I mean,
that's incredible. 7,000 people and 3 physicians in town.
That's smaller than Mount Pleasant, where I'm from, East Texas town.
So those doctors, a young boy, what I saw was, of course, when I went into their exam room for strep throat or get an immunization or something like that, but they were also super visible, most weeks of my life in Hillsboro. They were the mayor, they're on the city council, on the school board, chair of the school board, head of the Methodist and the Baptist and the Presbyterian churches, on the football sidelines, of course, at every game where the whole town was. So they're very visible. And so, we use this term population health a lot for the last couple of decades. Like if I look back, I was viewing population health for 3 physicians and how they cared for the community way more than just the exam room. I guess that left an impression on me, and that kind of dawned on me in my 30s as I was trying to figure out where's my role going to be in healthcare. You go into healthcare because you want to make a difference, and then you start thinking broadly of like how might you do that, and that experience growing up in Hillsborough really pushed the envelope for me to choose to go into primary care, and then to think more broadly again than just the exam room about how we might improve the delivery, because we can sit here all day and talk about all the problems in healthcare, and there's plenty of shows and people that do that. I'm more of a, hey, how do we roll up our sleeves and how do we make it better? And really, I've just been on the quest of doing that, starting with Village Health Partners and the medical villages we built, and now into Catalyst and Catalyst Health Group, and continuously trying to improve and help our communities thrive through bringing transformation of primary care delivery to our communities.
So, were anybody else in your family in the medical field, whether physicians or allied health or anything? Are you the first generation to enter that field?
Yes, and so something of note in 1987, when I was about to finish high school and kind of deciding, what are you going to be when you grow up? Moments when people are asking you those questions a lot. The savings and loan crisis hit my town pretty big, and it was a little devastating for me and our family and others, and but it wasn't devastating for the physicians in my town. I noticed, or at least that, and so I thought, I should maybe go be like that, because that seemed stable. So again, how your youth and how you grow up and where you grow up makes a huge difference on kind of how you choose to lead the rest of your life.
Yeah, no doubt. So did you take the opportunity to stay in Texas for your education?
All the way through. I got a lot of degrees from UT.
Okay.
College, medical school, residency, and then I even got an executive MBA my first couple of years of practice over here at UT in Dallas. So got a few degrees from UT.
Yeah, no doubt, man. That's a wall full of diplomas. That's right there.
Yeah.
Well, I think, most notably from your background, how has your work as a primary care provider, how has that led you to the founding of Catalyst Health Network and, the organization that it's grown into today?
So I guess probably give you like you said, you don't have a huge experience with primary care, and so maybe just some kind of basic global facts to think about. More than half of the encounters in healthcare on a daily basis between a patient and some type of provider, about half, are happening in the primary care realm. And you hear this value-based care buzzword. What does that mean? But if you think of it as there needs to be more responsibility for better outcomes of quality and cost and experience for the patient and whoever's paying for it, you think about a primary care being able to actually control like 90% of the cost and the experience that a patient has. And so when I was seeing patients in the exam room, it feels very limiting to be confined to a 9 to 5, Monday through Friday, 15 by 10 exam room as the only place that healthcare could be delivered to the patient, especially in primary care.
Well, I don't think I could do that.
Right.
Right. I mean, I don't know about you, Kelly, but
I don't do that. Right. I did it for 12 years.
Yeah.
And now I've been running a business that tries to make it better for the last 10. And so that was one of the unlocking moves, is we have to be able to do this better. We can't make the ability to get primary care, or really any health care, confined to time and place. Now, COVID has accelerated that, and we talk about telehealth all the time, but we were working on that 15 years ago, trying to make a delivery model where patients could get care when they need it, and not just when it was convenient to me. That's the difference of being physician-centric versus patient-centric. And so how do you create patient-centric models that ultimately show value in better health, better cost to the employer or the government, and hopefully it feels like a better career for the physicians? And we've been able to grow because we think we hit that triple aim every single time.
Yeah, we hear often about this idea of healthcare provider burnout, and primary care providers are the first ones that I think of when that term comes about in a conversation. How many patient encounters does a primary care provider have, a physician, in a given day? I mean, is it 20? Is it 30? Is it 70?
You could be 20 to 40, but if you think about the financing of healthcare heretofore has been this fee for service. So you think about things in units like how many cars got washed, how many mufflers got changed today. And what we need to do because the government and the employers who pay for healthcare think about their people as a population. And so what primary care has the opportunity to do, because you have a long-term relationship versus a surgeon who might just do a procedure and done, is how do you think about that population broadly? Your question is very much a fee-for-service oriented question. How many patients do you see today? Because that gets burned out. Well, that's a fair question. It's just the wrong model that we're trying to change it to. So it's 20 to 30 patients a day, 15 phone calls, and it's all reactive care. Reactive. Whatever the patient calls and makes an appointment, I go into the next room and I manage it. All you're doing is putting Band-Aids on people. And so what we have been aspiring to for the last 15 years is how do you continuously move to a proactive model to take a population and actually day to day be able to discern who in that population that's at American Airlines or Blue Cross Blue Shield or a Medicare Advantage population or in a neighborhood, a company.
Sure.
How do you take that population and make sure that you're able to figure out through data or relationships who you actually need to be caring for each day, and then create a team that's connected and technology to augment omni-channel communications so that the care delivery doesn't rely on me and my 15 by 10 exam room or a certain time and place, and you open it up to where healthcare can be provided continuously across a lifetime, and primary care being the front end of the care delivery that you need, and hopefully over time minimizing all the back end time and expense and anguish that comes from slowly, your diabetes didn't happen one day. It wasn't a car wreck, right? It was a slow progression. And so if you could improve choices in a patient's life 1% a year, that compounds. We say this all the time, relationships compound the same way your interest compounds. It's very, very powerful. And so if you could actually make those minor changes year by year because you have more frequent touches in that relationship with your team and technology, you can make a massive difference to the total cost of care and ultimately the trajectory of an individual's life. That's how we help communities thrive.
That's interesting. Kelly, I see you nodding your head over here a lot, right? You're on the administrative side. When you hear what Dr. Crow is speaking of and this want to transition models from this fee-for-service to managing the population for a longer period of time, what's the first thing that pops into your head?
Well, yeah, for me personally, I want to come back to the technology thing because that's super important. But what I want to hear from you is, what were the challenges, or the biggest challenges that you saw trying to implement value-based care?
It goes back to the question that was asked just previously around how many patients do I see a day? We get wired as physicians or in our jobs to just get on the merry-go-round of your exam room patients. And so exam room. So the biggest challenge, and I get this question all the time, is status quo, period. Like there's an inertia in healthcare of it's just the way it's always been done for the last couple of generations.
Boy, you're not kidding about that.
It is so freaking hard to pass through. And so I can go have dinner with a physician and they can kind of conceptually, it's easier for me to tell my teenagers what I do and why and the models that I'm trying to create because they're naive to it and they're not necessarily already wired, versus a very intelligent physician I can sit across from and talk about this with, and all they can think about is, but I got to see 25 patients tomorrow to pay the rent and pay my payroll and making sure that I can pay my mortgage and my kids go to school. So this extra stuff you're doing to talk about transitioning sounds like too much.
Yeah.
And so the status quo is really tough on that, and the financing model. You were talking about the financing model. The financing model of fee-for-service is so ingrained, and it's ingrained because here's how much the status quo has become solidified in our nation. If you go back, check me on this, fact check. 20 years ago, if you look at the Fortune 20 companies in America, there's not a healthcare one on it. 2002.
You're 100% right, actually.
You go to today, 8 of the top 20, 2 of the top 5 are in healthcare. Almost none of them are actually providing any care. A few of them are through an insurance company. And the other 12, about half of them are trying to get into healthcare. Walmart, Apple, Google. So healthcare has become into this place to where organizations go to get wealth, and maybe hopefully our citizens get a little health. It should be inverted, that it's a place where we're trying to provide health, and maybe a few people get wealth, but it's totally inverted now. And it's because that status quo is continuously returning dollars it's kind of the shadow of capitalism. It's returning dollars in ways that aren't necessarily helping the individual citizen.
From hearing, what you have to say, it's interesting. And also, it sounds like this model that you've built is helping physicians not burn out then, because we only ever hear that physicians are burning out. I mean, I see them every day in my business. They're burned out trying to transition to this value-based care. So what have you done in your model that has helped prevent that?
You have to tool them. You have to arm them with new things to help them make the transition, because it's hard enough mentally, and then the status quo is against them, and the financing tells them to just do more. Quality doesn't matter; it's more.
Right.
And so you have to get a little bit of the financing working that way, so you can reward. We're an incentive-based capitalist culture, like I said. So you got to get the incentives focused. Their heart is around, their soul is around trying to help patients get better. But they also got to make it to soccer practice and show up at other events, and so you have to give them tools. And so what we give them is eyes and ears and hands, extra hands that are working inside their electronic medical record on their toughest patients. Because their toughest patients, you've heard the 5% of patients make up over 50% of the cost. Those patients also take up the most time. And if you're putting people, and if everybody is supposed to fit into a 15-minute segment,
it's impossible.
You're very healthy, I'm middle healthy, and you're really unhealthy, and I'm only giving 15 minutes for each, then you're gonna always be lacking, and you'll just drift over time.
So are you taking care coordinators with a software that track
Working
these?
inside of the EMR.
Okay.
So I'm a virtual user. So our model really took off during COVID because everyone was virtual. And so having a pharmacist, that's in, so Kelly and Christopher are in your EMR with the doctor, working with you on your hardest patients, being your eyes and ears, letting you know what's going on with them if they're in the emergency room or the hospital, letting you know whether they're following their care plan, whether they're adherent to their medications. This isn't for everybody, right? This isn't for the majority of the patients who that are mostly healthy. Maybe they just have a small blood pressure issue. These are for the people that are taking up their most of their time, and they're the most complex, and actually the ones where you have an opportunity to, if you treat them well, and you are in a partnership with them, that they make good decisions, you can massively change the trajectory of their life and the cost. You add that up over a population, and you start to really impact the total cost of care, which if you're contracted in the right way, you should share in those economics.
Correct.
And so that's where you got to get the incentives right. You got to give them the tools and the services that are integrated in. And it's a slow change. Like most of my initiatives, I think will take a certain amount of time, and it's usually double. And it's because just getting behavior change in humans, specifically physicians, takes time.
Yeah, that's interesting. I mean, it's a marathon, not a sprint. That's the first thing that comes to mind for me when you talk about this. But the question that I have is, there's a lot of tools being deployed, a lot of levers being pulled, right? I think a little bit about, don't look at the man behind the curtain in the Wizard of Oz, and he's back there pressing buttons and pulling levers. How did you determine, looking back at your experience, how did you determine what was most important to pursue first?
Yeah, we used to get that question all the time, and there was a little bit of a learning as you go. We didn't know. I mean, there was no data to say if you throw a care team that has social worker, care coordinator, pharmacist, behavioralist, I mean, what matters? What matters at what ratio? Didn't know. But you do it like I've done it for 15 years. You start to see things. You hear stories first. You get anecdotes first. Yeah. And then you start to look at data, and you start to go, oh, that makes a little bit difference than others. So for us, we started seeing about 5 years ago, really interesting things around medication adherence and having a pharmacist involved with the physician, a named pharmacist, not robo pharmacist or the same pharmacist that relationship became really interesting and massively changes the total cost of care now on an annual basis.
That's interesting. I would never in a million years think
Yeah.
that would be the case, right? That's where.
That's why that pharmacy company is taking off and going national and spinning out, because it's so impactful. So that's one.
Okay.
Certainly, transitions of care are really important moments, and it actually connects to pharmacy, because one of the main reasons that you get a transition back into the hospital or readmission is because your medications are messed up for a variety of reasons. But if you look at what CMS, the government's done a really good job of playing the long game and slowly, because they have these beneficiaries for forever, whereas insurance companies, they change every year or two.
Right, they're trading.
Right, but the government is invested in long-term projects, so to speak, to lower the spend, and so they've seen just tremendous value in paying attention to the transition to care. So much so that they created penalties a few years back for if they got readmitted. You may have heard of that.
Right. Yeah.
Yeah,
Right.
within 30, right?
Right.
If a readmission for
That's
the
right.
same issue happens
That's right.
within 30
And
days.
so the post-acute world of skilled nursing facilities, rehab, it's not as dirty as the PBMs or the pharmacy benefit managers,
Yeah.
but it's an interesting space of a lot of costs, home health, and
Yeah.
so paying attention at those transitions of care and putting someone that's dedicated, or a team that's dedicated that includes a pharmacist, so that has returned an ROI. So again, you could have a theory of that, but over time you got to get a lot of population. We have over 500,000 lives that we care for on an annual basis that are attributed to us, and so you can start to see patterns a little bit easier when you have that big of an N.
Hold on. So you're saying you just said 500,000 lives?
That's how many are attributed to us.
They're
Our
attributed
practice,
to
we have
you?
about 1,000 PCPs
Okay.
across different parts of Texas, mostly in Dallas-Fort Worth, but we're in East Texas and going into Amarillo and Central Texas. And so, there's in those practices, there's primary care physicians, we probably have over 1 million lives. But the way the attribution works, like those are people that come across our the need for our services at some point, potentially throughout a 2-year period. That's what we call attribution.
Okay.
And that's about 500,000 lives.
That's incredible. I mean, that definitely is at scale,
Right.
where you can see patterns of behavior and patterns of data occurring
That's right.
that allow you to really make some decisions.
We're absolutely a geographic scale. Our in Dallas-Fort Worth, you think of the big groups of Texas Health or Baylor. I mean, we have a similar population, even though we're not a health system. But we're impacting the same amount of lives from the primary care setting.
Yeah, no, that's tremendous. You've been a vocal proponent for changing how payment structures are set up. Maybe talk a little bit more about why that's necessary outside of physician behavior. Well, maybe let's pull the curtain back here a little bit and talk about why it's necessary and what you're seeing already in that move where you've had some success.
Yeah, it aligns incentives better for a primary care physician and a patient relationship when you're paid kind of prospectively and longitudinally versus episodically. Let's peel that back a little bit. All right, it's very different in a surgical world.
Absolutely.
But if you believe in that relationships matter and that they compound over time, then if you could get ahead of the game, instead of not having reactive care and have proactive care, you actually rearrange your operating model for a primary care physician, for a population, from exam room to, let me take a broad view. Who needs me today? How do I create teams and technology that can reach people in the most important moments and keep staying with people that we need to pay more closely attention to? So you rearrange your operating model, number one. And when you rearrange your operating model to teams and technology that focus on the people that need the care most, those relationships with those people, remember you were stuck in a 15-minute appointment when you needed an hour.
Yeah.
Now I can go spend an hour with a pharmacist, with a new patient that needs us online. We can dial in their daughter from Philadelphia and spend a lot of time and build trust. Behaviors that we want to change are going to happen kind of what we say at the speed of trust, and trust is based on relationships. And so rearranging the operating model allows you to start thinking longitudinally and start thinking broadly rather than just episodically. And that's the kind of we call fee for service the devil. because it keeps innovation out of the healthcare system on primary care, and it keeps relationships from being able to be built because of the episodic nature of it.
So, aligning financial incentives for the providers is one thing, but how do you align financial incentives for the patient? Right? What's happening on that side of the house?
That's a perfect example then, because that's great. To understand what's the patient experience then is there's no longer these co-pays or co-insurance in the same way. It's you come in and you have a relationship. You see them when you need to. The physician no longer has the incentive to say, hey, you got to come in and see me for me to check your blood pressure before I refill your blood pressure medicine. I mean, do I really need to see you for that? No.
It's a waste of time.
But no, it's not, because it's the only way I get paid. And a fee-for-service model.
Yeah, this is true.
Right? So you have to appreciate the incentives. In a prospective payment model, the patients are not in a fee-for-service mentality either. And they understand that they have a team of people that are available to them omni-channel at any time. And sometimes that may mean that they come see the physician, but there's not necessarily a copay then, or they're not worried about their deductible in that situation.
I saw that all the time in primary care.
Right.
Yeah. No, I mean,
people don't want to come in because they have a deductible.
That's right.
That changes.
I shouldn't have to pay my copay to get my blood pressure checked again, to get my pills. Like, quit holding my pills from me. I would see that all the time. You know what I mean? For things like blood pressure or to review lab results, right? We would see that, and so that's interesting.
Well, it's in conversations that you and I share a colleague that's on the insurance side of the house, right? And works for one of the big four. We know emphatically that high deductible health plans have not done what they were set out to do, which is through financial penalty, create behavior change. So then the question becomes, how do you take the patient by the hands, especially in primary care? Question for me is, if we're having our first encounter, and what's the story that's being shared with me, with the physician and the care team, to get me to buy in?
Yeah, that's right. That's a great question, very real life question. So we gotta assume you have diabetes and high blood pressure and cholesterol issues, and you're 50 years old, and you haven't really been taking good care of yourself during your 40s because you were an athlete when you were younger and didn't want to admit it. And so you come in, and finally you've known your doctor, and you see him every 2 or 3 years, and your wife wants you to come in and see annually, but you don't because you're too busy. And so you finally come in, and you've kind of had a little scare because your buddy died, and so your doctor's talking to you and says, hey man, when are we going to finally do something about this? You're up to like 6 or 8 medicines. You're never really following up the way I want you to. I got this I'm a part of Catalyst now, and so I have a care team now that can work with you. I know you're a busy guy, but we can get a pharmacist that's with you regularly. We can get a kind of a care coordinator, because there's some stuff you need to do on an annual basis. Now we got to check your eyes. We're going to check your heart every now and then. We want to make sure we're keeping up with you and making sure that you're following a plan, helping you. If you need some nutrition help, we got nutritionists, we got diabetic educators. You want to go on insulin? No, I know you don't. Yeah. So let's get you involved with my care team. So what I'm going to do right now. So this is at the end of the visit. We've talked about this, and you're starting, because you trust your primary care physician. It's not your first time. You've been with him long enough. You're like, you know what? He's probably right. I'm ready. And so we introduce, probably at that point, maybe our pharmacist, real time, bring in an iPad, say, hey, meet Tony. Tony's going to talk to you. You're going to set up a little time with him. And then Tony's going to come back and spend time maybe with you and your wife for an hour, talking about all your medications, talk about what you believe in, talk about what you're scared of, talk about what your barriers are to care, whether that's, maybe in this case, you're not a big executive, you're someone who has transportation issues, language issues, cultural belief issues. How do we understand who you are and get you better known to ultimately find out how we can overcome barriers to get you to better care? And that's just the beginning of a conversation that then lasts.
Right, which is interesting, right? Because now you're dealing with root cause identification, not symptom identification and masking.
Behavior change.
Correct.
Behavior change. People don't want to be unhealthy and overweight and take 6 medicines and insulin. I mean, there's a disease called Munchausen, but very few people actually want to be non-compliant and unhealthy. And so what are the reasons that we got there, and how do you peel them back one by one? And you can only do that if you're committed to a long-term relationship and you're paid in a way They want you to stay in it and build systems to help people over time do that.
How do you break down the physician's reluctance to invest in the care team model, right? Because I would think that that's a big barrier.
100%. And so part of what Catalyst was built of is for us to take that burden. So we work with colleagues that you know and payers to create a contract that says, hey, give us some dollars to put some infrastructure in to help the physicians with teams and technology, because every little doctor's office can't go duplicate all this. I mean, I ran Village Health Partners that has 50 providers. We wouldn't probably even have a pharmacist. But now they have a bunch in a scaled system way.
That's interesting.
Right? And you wouldn't have a care coordinator. You wouldn't have a social worker. You wouldn't have those things. Because in a fee-for-service world, they're just paying you for your office visit.
Yep.
And so you don't have any money. Remember I said there's not enough money in fee-for-service to invest and innovate? Now you got a system to where we've created the infrastructure. Then we create the opportunity. If we provide good care and you lower the cost and you meet the quality metrics, then you get to share in that. So now the physicians are starting to get a little bit interested because they got help.
Right.
There's not a physician out there that wouldn't say, hey, I'd love one more MA. Boy, I'd love another set of hands. Oh, that'd be awesome if I had just a pharmacist sitting here so I don't have to talk to Walgreens all the time.
Yeah.
Right? And so we provide that. And so first we give them help. Then we give them a financial incentive to do things. And now all of a sudden they start to have hope.
Yeah. Which has been, by and large, hope has been lost with independent physicians for some time.
Yeah, the burnout rates are, I don't know, they're closing in on nationally. What are they, like 70%? Depends on whatever study you look at. I mean, consistently our physicians are generally about half of those burnout numbers. I mean, it's not zero, especially post-COVID. I mean, everyone's kind of clicked to the right a little bit on the mental health side, but it's always a lot better because they feel the support that they get. That they're not having to figure out and invest in. There's also the investment of dollars, but there's also the investment of time. And these physicians generally weren't built to run Lean Six Sigma businesses.
Yeah, we were talking about that before the show, right?
That's right.
That's interesting. As we talk about all these things, we're talking about there's people resources, and then there's technology resources. What have you found to be the most beneficial technology resources that Catalyst has invested in and seen a return on?
Yeah, I would say there's two, three really. One is getting physicians real life data about their population and where they sit vis-a-vis each other in some kind of quality or utilization or cost metrics, whatever that scorecard is. Whenever I'm speaking to a room of physicians, it's a fun trick I always do. I always have them raise their hand if they think they're above average.
Yeah.
And all of them raise their hand. And then we talk about the definition of average and how that would be really wild that everybody in the whole room was above average from a statistical standpoint. So you start to show physicians their data, and they do all the stages of grief. First they deny it.
Yeah.
Then they get angry and they bargain with you. And I'm a physician.
I was about to say that, coming from a physician.
I remember the first time I saw my data in 2004, I started pulling on myself because I cared about what I looked like. And I was like, damn, I'm not very good at diabetes. I was pretty good at blood pressure, but not good at diabetes vis-a-vis this group I was being compared to. And I fast cycled through my grief and just figured out, let's just go figure out a way to get better, right?
Yeah.
And so that really matters because people's behavior changes based on feedback. I mean, it's feedback. Yep. And so that's a really important piece to give physicians feedback. Otherwise, they create their own story and they raise their hand when they say they're above average.
Right.
Number two, technology. So that's a report card, but I'd put that in technology. Amazon, takes way better care of tracking and knowing where our toothbrushes and toilet paper are than we do in understanding where our patients are in the healthcare system at any given time. It's, hey, how about I give you a card and you can go see my buddy. He's a cardiologist. Just tell him I sent you. Oh, you need a colonoscopy. Here's a sheet of paper. I'm going to tick this off and write something on it. Go get yourself a colonoscopy. I have no idea if you went to the cardiologist. I have no idea if you went and got that stuff done because the specialists rarely send me a note back because what's in it for them to do that? They don't get paid more by sending me a note back. And so about 10% of our referrals, we ever even get anything back. Okay, so why don't we have a technology? If Amazon can do it with toothbrushes and toilet paper, why can't we do it why shouldn't we should do it for our humans
Yeah.
that we
Right.
take care of.
So you know whether or not they're following through on what's needed.
That's right. And so what we've done, that's one of the cool things we did at Catalyst about 6 or 7 years ago when we started. We really pressed to actually connect not only the primary care offices, but all the specialist offices, all the ancillary services, all the facilities, even atypical, whether it's a chiropractor or a massage therapy, et cetera. Now even with the social determinants like food banks, and et cetera, to transportation services, and making sure they're all connected. So if I'm sending you, or my care coordinator is sending you to XYZ, let's go colonoscopy or whatever, that it's being tracked. It doesn't matter what electronic medical record, and everyone's communicating. So we do, I can't even know now, hundreds, thousands, referrals a day. When I say referral, it doesn't have to be just the cardiologist. It's any of those services, anything you need.
Yep.
I'm tracking and I'm watching, and I can see when it was accepted, when it was scheduled, when you went, and then I make sure I can see if there's a note that came back or not.
You can see if there's a
We're up to about a 4-day. When we first started doing this years ago, we have over 7,000 providers, whatever of those categories, connected in Dallas-Fort Worth, and we have about 4-day time period on average to get to a specialist when it started at 30, and we have a rate of return of information about that patient back to the PCP, which matters. I mean, you send them, you're communicating, you want to know what's going on. It's in the benefit of the patient for us to be communicating. That's up to about 67, 68% when it started out at 10. So we feel like that technology has, going back to our purpose of helping communities thrive, has done a whole lot. And every single physician and ancillary group, resists it because status quo is powerful.
Correct.
And they want us to fax stuff. And I'm like, no, we're not faxing. That's the only reason we have fax machines is because of healthcare. We're not doing that anymore.
Yeah, it's the only place
we have these things and all this. I mean, we should be able to electronically track if I send someone to a cardiologist, and you should be able to send me information back. It doesn't matter what your EMR is. And so we've done that and pressed. I remember the day when we got a call from UT Southwestern. They were like, "Hey, Catalyst, we got on it so you could communicate with us." And so we make sure all the hospital systems are on it, and that if you want our patients, you're going to have to communicate with us this way. We're in Dallas-Fort Worth. There's 250 spine surgeons. We probably need 10.
Yeah.
And so if you want me to
Keep
fax
moving,
it, I'll move to the next one.
Yeah.
Right.
So this is a software y'all built then?
No, we co-developed it.
Okay.
So that was number 2. The last one is our pharmacy that's so powerful that we've got probably 40-ish software developers, a lot of them offshore, of what we've done to actually put that moment of when I'm trying to get you to begin that behavior change, and I put a pharmacist in your pocket, so to speak, to be able to communicate with me, you, each other, and be able to track on an ongoing basis how you're doing with your care plan and your multiple medications, and be able to track that. That technology is super powerful and engaging to keep the patient on track.
What do you think the economic impact has been of your pharmacy program?
Depends on the cohort. So on the commercial lives, we've seen as high as several $100s per member per month in savings. Remember, we do only chronic, so our average patient is on 6 medications.
Yep.
Average patient, right? We may catch them at 8 or 9, but we get them to 6. We're always going to lower their costs just in their utilization usually, because instead of being on 3 blood pressure medicines that they take 60% of the time, we convince them to take 2 100% of the time.
Yep.
And so they've dropped a pill, saved some money, and their blood pressure is under control. And for the first time ever, the physician's like, I actually know what's going on. Because when you come in and tell me, and I say, hey, your blood pressure's still kind of average, what's it been running at home? And you say, oh, I don't know, it's this and that. Are you taking your pills? Most of the time. What the hell does that mean?
Yeah.
What am I supposed to do with that? Okay, I'll just give you another pill that you'll take 60% of the time.
Right.
And so now we got it to where it's only 6 meds on average, and if you track those people a year before, and then you track them a year after, usually that cohort, it's several $100s per member per month on Medicare.
That's huge.
Massive.
It's huge,
It's
especially when
massive.
you're dealing with a half. let's just say you're dealing with 100,000 lives.
Yeah,
with that.
that's right. And so far, we got thousands of patients that have been through that program multiple years. We usually don't lose people, and we've shown that it's not like just a one moment, one trick. It stays. It sustains year after year after year. It begins to compound, like we said. And so that's a really powerful one. We've had a cohort we did for a big payer the other day where they wanted to take some of their higher cost. We took their higher cost 100 patients and looked at what the impact of our pharmacy program on them, and it was like $1,200.
Oh my gosh.
Yeah. And they were like,
wow,
we want that everywhere. I was like, well, let's go.
Yeah. No, I mean, that's great. I mean, as we start to wind down our conversation from today, time's just flown by, and this has wildly opened my eyes to what's going on the primary care side of the house. What do you think is your most significant barrier to continuing to make progress at the pace that you've been making progress?
It's still status quo. That continues to be the number one barrier. Primary care and value-based care is a very hot area. People understand the power of it because again they make up half the visits. They can control 90% of the costs. The relationships are how behavior changes. So there's unlimited capital. So capital's not a problem. Mm-hmm. Technology is everywhere now. I mean, it can be built so fast and cheaply, and so technology is not a barrier either. The barrier is status quo on the behavior change of physicians as we grow and grow,
yep.
And then the financing model in healthcare moving from a fee for service and getting more and more into a prospective payment. So that the status quo of those two things are the things that continue to make it a slow transition.
Kelly, what additional thoughts do you have to blend in with this convo? You've been such a good listener, but I know that brain of yours is constantly moving and thinking.
Well, hearing them talk now, I want to know, a lot of physicians out there just blame the payers, but you haven't mentioned that once being a barrier. So talk about that for a second. How have they either helped you, teamed up with you, or just talk about that. Why do physicians, if you're doing this so well, just I guess talk about that, and how do you not see them as a barrier?
So they when I say that moving from fee for service to prospective
mm-hmm.
payment, they're the barrier. I mean that is the status
okay.
quo. Their systems are too old. They can't pay it that way. Although they pay it on the Medicare Advantage side, they don't pay it on the commercial side. So they are the barrier in that particular aspect of what I'm talking about. And at the same time, they are our partners because that is how we negotiate these, and that's how we got started. I mean, the 4 major payers came to me when I was at Village Health Partners and said, hey, can you take what you're doing in that little bitty area up in Collin County, and can you explode that to the entire network of or Metroplex? And I said, yeah, we can try. Here's what I'm going to need. I'm going to need you to help me give me some funds to build an infrastructure. I need to have the incentives built so I can go to the physician and show them that if they use this infrastructure, how it'll make their time better and how they can make more money. And so they were partners, and they still are our partners.
Right.
But the fundamental issue that we're going to have in healthcare broadly is until we actually pay primary care a prospective population health type payment, they're going to stay in a fee for service model that's reactive versus proactive. We're stuck. We can't move forward, and all the other fun things you hear about in healthcare, whether it's a surgery or whether it's a new technology that people can do telehealth from anywhere in the world and all yada yada yada. Until we get the incentives right around the financing and how actually we primarily take primary care
mm-hmm.
of our population, we'll continue to just get a little bit worse and more costly every year. It's not how you would set up a new country. Imagine
it's almost better if we could just flat start over.
Exactly.
Versus trying to remodel the money pit, right? Mm-hmm. That's kind of.
There's plenty of money. By the way, we don't have a lack of money. Like I said, it's how it is divvied up and how it's paid and incentivized.
Interesting. Do you think that's institutionally an issue with the payers, or do you think that it's leadership being afraid to step out of line from what the norm is at these payers? And have you had any experiences where leadership has said, hey, we're willing to step out of the line here and be more exposed than
Yeah.
any of our competitors.
Look, remember I told you that 8 of the top 20 health companies in America, from a Fortune 20 standpoint, are in healthcare. 4 of those are the big 4 payers. There's good people inside those. There's good people who want to make a difference and would like to step out. But when companies get that big and they're all public, and
Yeah.
they all have to get a quarterly earnings, especially in America today, you never can get an initiative that really, or not never, you rarely can get an initiative that has a long tail to it to get an ROI passed inside that organization, because you gotta get your earnings per share hit every quarter. This is the long play. That's why the government is the leader right now in this, because
That's
the government
so interesting, because that's
the
normally
government-
the opposite.
That's right. They're absolutely the innovators in all this. They have the incentive. They're incentivized to do that. The payers are like, I'm not going to have this patient anyway in 2 years.
Yeah.
So why should I go spend a bunch, update my IT systems? That's going to cost money. That's going to hit my earnings per share next quarter.
Well, that's really interesting.
Yeah. We don't, and I think the average consumer thinks of insurance companies as knowing a lot about patient care, but in fact, they know essentially nothing about patient care. They're an accounting and an
Actuarial.
actuarial company.
They're an actuarial company.
Yeah.
Mostly. Now, again, they're doing a lot of other things, and I see the kind of the role and how it emerged, but it's gotten. I mean, the pharmacy benefit managers are a great example. It's gotten out of control.
Mhm.
Of again, these are now wealth engines, not health engines.
Yeah. So what's your goal with Catalyst Health Group? Is it to really become a true national organization?
It hadn't been until recently. I look at what's going on right now, and back in the reason we started actually is because hospitals started consolidating and prices were going up across the country. And so we, 7 or 8 years ago, they came to us and said, hey, can you stabilize the market with all the independent physicians before they go into 2 systems? And we did. We stabilized the market. That's not really the buyer now. They're actually trying to get, a lot of hospital systems around the country are trying to figure out ways to keep aligned with their primary care physicians, but not own them anymore. Your big buyers are the insurance companies right now, because they want to get into the. If you think about an insurance company and they take the premium, they're paying out all the dollars to providers. One way to grow and meet earnings per share. What if you own the providers? So you see that happening a lot. That's physicians want to. In a perfect world, they'd like to work for themselves in an organization that's aligned. Hospitals are about filling beds. Primary care would like to keep you out of the beds.
Yeah.
An insurance company goal of earnings per share is not going to be necessarily what a physician's goal is going to be with a patient. And so we think we've now created a model that has gotten a lot of traction. It's across all payers now. And we think as the world continues and there's been a lot of consolidation, we think we'll see a swing back. I mean, there's I don't know what the latest numbers are, 30% or so left of independent physicians. There's been a huge pendulum swing. We think it swings back, and we think we're there with our platform to catch potentially nationally. Physicians like when you can solve something for all of their patients. A lot of models out right now are just for Medicare Advantage or just for Medicare. Our model is for all your patients, and that's very attractive. And it's in a team-based environment where values their time, and then we try to create the right incentives to if they perform with their patients, they're rewarded. So we think that's a win-win-win that will hopefully continue to get to grow. We have the last 8 years and hope to continue to.
What a fantastic story. This has been a really enjoyable conversation for me, because I am one of those people that relies upon primary care, right? Most of us have that relationship. What are your calls to action with the healthcare community, and in particular, primary care physicians who might be listening?
Yeah, I think for primary care, I want them to have hope. I really do want to have hope that there's actually other models out there in the country. That I don't think our model is the only model. There's 300 million Americans, so I'm not about to say that I'm about to go take care of 300 million Americans. We've got 1 million, but have hope that there's a lot of things going in your favor. Again, you control more than half the relationships now on a daily basis. You actually, with your relationship over time, control 90% of the costs. Find good partners who are aligned with what you want with your patients. In this market, obviously, we're one for sure, and really look for that, and don't think that you have to just give up and say there's no more hope. I have to go be employee number, 122,704 for the 8th largest company in America.
Yeah. No, I think that's a fantastic call to action. Kelly, any departing thoughts from your end as you've listened and engaged here?
In what ways do you envision yourself partnering with specialists closer? Is it only just keeping them in the Catalyst network? Or
we don't
is
have
there-
any specialists in our
Okay.
in our network on purpose. It really helps with governance, quite frankly,
Okay.
and singular focus. And so, whether it's specialists, hospitals, ancillary service companies, it's a team sport to take care of people over a lifetime. So while we may hold the relationship and have a team-based model, very often you're going to have to go outside of that. So it's very incumbent for us to continuously make sure that our hospital partners, our specialist partners are getting good communication and are getting good input on what we're up to, and that asking the question of what we can do to help more, so that the inverse question works too, of like, hey, here's how we need you. We want to track our patients, for example. We want you to send information back. Well, how can we help? And so that reciprocal relationship is really important. So defining those specialists that are more oriented to that is important, and then continuously feeding that relationship positively.
Good.
Well, awesome. Well, this has been a tremendous conversation. I'm certain we could sit here for a couple more hours and just keep talking about this, but I think we'd lose some of our audience. So we'll say that's it for today.
Perfect.
But look, folks, if you're listening, these types of conversations are going to continue to happen. We're going to continue to push to engage with folks who are innovating in our healthcare marketplace. Find us on LinkedIn. Find us on Facebook. Find us on YouTube. All of your traditional social media channels are available to listen to these podcasts, and in particular, share this with your friends or your colleagues. We're up on Spotify and Apple Podcasts too. So for today, we're going to wind it up. Dr. Crow, really appreciate you joining us and sharing this conversation, as we know you're a busy guy and clearly on the move. So
Thank you both for having me.
absolutely,
Thank you.
been a great time, and we'll call it a day.
All righty.
Thanks, guys.